Hello viewers, again in this week we are with a new topic and with a new faculty from our own country and from our own Indian Academy of Pediatrics. Today's guest speaker is Dr. Nagalatha as she is going to talk and going to update you all about the fresh feeding from instinct to skill. She is MBBS DNB IYCF IBCLC International Board Certified Lactation Consultant, Consultant Pediatrician and Lactation Consultant at Bangalore Memorial Hospital, National Trainer of BPNI for IYCF Counseling, has been Divisional, State and Zonal Quiz Coordinator and Quiz Master IIP for the undergraduates and postgraduates. Executive Board Member of IIP BPS 2020-21 on SAT IIP Infectious Disease Chapter, Karnataka State Branch 2021. Editor of Pediscan 2023, Joint Secretary IIP BPS 2024. Section Co-Editor of Algorithm Book of IIP, Editor Sub-Section Postgraduate Quiz Book of IIP. Faculty speaker at various conferences of IIP, Bangalore, state at the national level. Lot of qualification and lot of experience. Our aim of this Dr. Tuteja talk show is not any appraisal of anybody, but to enlighten the society with the new faculties, young faculties, in front of you with the abundant knowledge they have got, and we want to update the society of pediatrician and public. Your suggestion, comments are always welcome. If you like the channel, you can subscribe it and encourage us so that you are updated with the new information. I humbly invite gracefully Dr. Nagalatha ji for the talk. She can share her slide and we can start the session.
Yes, thank you so much, sir. First and foremost, it is a privilege for me to be in front of you. I'm a little intimidated also looking at I've heard a lot about you through a lot of people. Preeti madam told that you are being mentoring a lot of people, and we have heard all your talks through your Tuteja's talk show. It has been very useful. Crisp messages are there. I hope I do justice to this topic, and I'm honored to be with you here. Thank you so much, sir. Can I share my screen, sir?
Yes, sir, please. Yes, madam. You go to slide share.
Yes, sir. Is my screen visible,
Yes.
sir?
Till now not. Yes, it is visible now.
Yes, sir. So this is a topic very close to my heart, though whatever introduction is there, I would just call myself a mother, a pediatric postgraduate teacher, and humble lactation learner, in fact, because a lot of things are still to be learned. So it is a very close topic, which is very close to my heart. Thank you so much for allowing me to be there with you, sir.
So we start with as you have mentioned that the breastfeeding is natural and instinct to the skill. What is your take on it? Would you please
Yes, sir.
explain?
Yes, sir. So everything, I think it is God-given and a natural gift for all of us. So breastfeeding is also a same is what I believe, and it's an instinct. So whenever we say there is breastfeeding, it involves primarily two people. One is the mother and the baby, and of course, lot of us healthcare workers are there, and family members. All of us are there, but primary two people are the mother. Is the mother trained anywhere? No, mother is already prepared. If you look at the biology of the mother, mother has started preparing as soon as she is born. The mammary gland is there. At puberty, the mammary glands are developing. At pregnancy, if you know that there are a lot of changes which are happening. So hormonal triggers are there for her to milk, produce the milk, eject the milk, it is there. So it is natural for a mother. Now coming to the baby, baby is also biologically programmed from birth. What happens? The main things, but what is required for us is basically rooting reflex, sucking reflex of the baby. Do we teach the baby how to root suck? No, it is always there. So what I believe is breastfeeding is definitely natural. So because I chose this topic, I know we are all mammals. As per definition, we know we have a mammary glands that produce milk to nourish the younger one. So biological defining characteristic of human beings is because we belong to mammalian class, we are naturally programmed for breastfeeding. And few of the interesting facts which I just wanted to share when I was going through this topic is I went through a lot of veterinary lactation textbooks and some references. Lactation failure, that is true lactation failure, is not at all a norm in any of the mammals. It is not documented anywhere. Maybe there are some natural selection, some issues of malnutrition and endocrine diseases in the animals which might hinder, but overall there is nothing called as a true lactation failure. I would say that lactation failure is not a biological defect, it's a cultural and systemic injury which is unique to us or the human beings.
So, is it possible that we go through these challenges with the cases? It is a bit big question. Maybe starting from birth till 2 years, different age group challenges. Can we have a case example in early days?
Okay, sir. Yeah, I would. Yeah, that is an interesting. What we can actually follow is breastfeeding journey starts as soon as the baby is born until 2 years. So there are a lot of hindrances which can be there, a lot of challenges can be there. I'll just give a small example of what instinct versus learned skill would actually mean to us. I'll just take a simple example, which is in the early days, which is crucial for success. So I have written two cases which are contrasting here. I've given the names. Let us say that Mrs. Ria and Mrs. Priya are two mother and baby diet who have delivered. Mrs. Ria delivered a term baby. Both mother and baby are healthy. Because it was a normal vaginal delivery, baby was put to skin contact. Within 30 to 60 minutes, the baby was fed. There was active alert sucking, and every 2 to 3 hours, baby was fed. I'm sure all of us agree that there was a good latch effective suck. What happened to this mother is there was no nipple pain. Mother was confident and she has normally fed. So there was no problem for the mother to feed, and here the mother did not require any support at all. In contrast, let me just give another example where Mrs. Priya delivered. Mother and baby are healthy, but whatever was the reason, mother underwent a LSCS, which usually happens in many of our hospital settings. Many a times, because of unknowingly, wantedly, unwantedly, there are certain separation which happens during a cesarean section. Sometimes the infant is separated for observation, or mother is sedated, or they have to shift the mother and baby to a common room. Many a times this delay takes 5 to 6 hours. So what happens in this period, many a time baby is given a small amount of formula or so. Then this mother also, similar things happen. After that, when they were shifted together, the mother tried to feed the baby, but then she found the baby was sleepy and poor arousal was there. Hardly baby used to feed for 2 to 3 minutes. There was weak suck. So mother felt that she hardly any had milk, and then there was delayed milk initiation, and this is where the mother started having pain and she was not able to feed as much as the first mother. So what I would like to say is both mother and baby were healthy, but what happened in both this contrasting is sometimes the instinct works, but in the second case where the mother was having certain issues, what we as a learned pediatricians or the lactation counselor, we need to recognize where a skill is required. If this mother was given skin to skin, if this mother was given a alternate way of feeding the baby, or if she could express, maybe she wouldn't have had issues with the breastfeeding. So this is a contrast where I would say instinct versus a skill actually is required.
So, what was working in first instance with Ria, which was not working, there was hindrance in the second case.
Okay,
So, what could be
so
the cause for that?
okay, I would say that many of these breastfeeding failures are generally, if I could say it as, it could be a system induced. I Most important factor which probably would have happened here is the disruption of golden hour. We talk about golden hour in CPR, we talk about golden hour in neonatal resuscitation. All of us know that there is a golden hour in breastfeeding as well. It's an extremely important aspect which we have to follow, and there are a lot of things which are happening in this golden hour. I already said that baby is pre-programmed, hardwired to do the sucking. So baby is ready with rooting, sucking, swallowing, all these are already there. So, but what happens, what we have to remember is, if there is no opportunity for the baby to be fed, then it is a little hindrance. So, it is known that these reflexes peak within 30 to 60 minutes. It's an interesting fact that the strongest suck of the baby is often in the first hour. This is one point for us. And then we all know that breast crawl is a documented phenomena. What do you mean by breast crawl is, you just cut the umbilical cord, put the baby on baby's tummy. Baby actually crawls over the mother's tummy. It knows where the areola is, because areola is darkened. The Montgomery tubercles of the breast, that will have secretions very similar to amniotic fluid. It knows where to go and latch. So what I've shown here is the breast crawl. So baby is actually ready. If you're disrupting, there could be a lot of issues could be there, let alone cutting the cord. If we have to know an interesting fact, cord length is an evolutionary perfect. It's not accidental. See, it is around 50 to 60 centimeter. Even if you don't cut the cord, you just put the baby without cutting the cord, baby can reach the breast. So that is how the nature has made the breastfeeding so wonderful. Okay. So, and what I feel is the colostrum, even though it is a small part of it, it is so little for the baby to have it. So immediate breastfeeding changes, whatever happens, there is a lot of hormonal cascade is happening. So this is a golden hour. So that is what probably was missing with Mrs. Priya. So there was a delay, there was an initiation. So what we realize is, if you just look at this picture here, from birth cry to sleeping, baby goes through lot of instinctive stages. So this phase, if you miss, the baby is actually going to sleep. The first hour, baby is extremely active and ready to feed. Though you miss and there is a delay for 6 to 7 hours, and then if this delay happens, the consequences can be very large. So it is not about the initial lactation failures, are actually the missed first hour opportunities. I'm sure animals do this perfectly. Sometimes we complicate it.
Next question. I
Yes.
am sure that there are instances where golden hours goes on very well, as you have explained very well, but still lactation issues can come up.
Okay, so yes, sir. So breastfeeding journey, I told is till you 2 years. I will just take a simple example here. So let us follow something like, now we golden hour is all right. What can happen on second or third baby? I'll just give a small example. This is a routine for a pediatrician whenever we go for rounds. The second day you go and the mother says, Doctor, the baby was crying the whole night. So she feels, some nursing attendant expressed, they feel that milk is not coming. This is an universal problem, and my baby was given formula, and all of us start equating an excessive crying baby is always a hungry baby. So crying is just a communication is what I would want to say. So third day, fourth day, this mother started having pain, fullness, engorgement, and baby was not able to suckle. So what happens in these situations is, a mother feels that there is no milk, but you have to make sure that you weigh the child, see if there are any issues. Only then we will see. If the baby is having good weight, even in spite of golden hour going on well, if you don't correct these perceived milk insufficiency, things can be little difficult. So in this particular case, what was the remedy? This mother said that there was no milk, we have to understand certain things. Like what we do in the golden hour, we have to second, third day, what we have to do is when a mother says there is no milk, please remember two or three things which we have to see. Here there is a wonderful picture where you can see the newborn tummy with the breast milk. Say newborn tummy is just like a cherry which accommodates only 5 to 7 ml of the milk. Does the baby require more? I'm sure the colostrum is also nature made only 5 to 7 ml. So it is, if the as the baby's stomach size grows, the milk capacity also increases. Also, it is to be remembered that colostrum is biologically dense. It is not always visible. Many of us feel it is difficult to express. Here in this situation, they felt that it was difficult. What we have to remember is colostrum is designed for baby's mouth and not for the pump. So what is actually less is exactly enough. So to express, if there is, it is hard to express doesn't mean it is insufficient. It just means that it is perfectly perfect match for a newborn physiology. So these are, see, a few things on day to day practices. We should see the challenges and make sure we either counsel or do the corrective measures.
Next, uh, great going. If breastfeeding is instinctive, why does something like breast engorgement, where milk is actually abundant, suddenly make feeding so difficult? Is this where the instinct need learned technique or to succeed?
Yes, definitely. So I would say that just one part where I would want to say is whenever we say engorgement, there are two things which we have to remember. Engorgement always is a pathological. Sometimes when we say abundant milk, which is available, can be in a full breast, which is physiological, where the flow is easy. The moment we say it is engorged, we need to think that it is a hard breast, tight breast, where the breast is shiny and there is clogging, the flow is obstructed. So here, though milk is there, two things we have to remember: the cause and the effect of engorgement. So what happens, why this engorgement happens? In the previous cases, say there was no disruption of golden hour, baby has not fed, and there is mother has not expressed, she might end up in engorgement. Or second case also, the mother was given formula because the baby was crying, then also she can have engorgement. So what happens in these situations is baby has not yet learned to suck. So nature has made the breast is very soft in 1 or 2 days, and baby is easily able to suck. They go, it is soft, a small amount of colostrum is there. But third day there is a phenomenon what we call as milk coming in happens. So where copious amount of milk starts coming in, that is when the breast is getting adjusted. If the breast has not been suckled, see, if you can just see the picture, that tense shiny skin is there, areolar edema is there, flattened nipple is there. The baby which was not given a try of sucking at the breast when it was soft, it finds difficult to suck, where the baby will empty. So if though there is abundance of milk, there can be issues. So this is the cause why the baby will not get, even though there is an extreme amount of milk. If this is not corrected, we can just see the consequences which can happen. Mothers can end up with abscess, inflammation, lot of tissues can be there. I'll just take a moment, sir, 1 minute, to explain whatever has I've summarized, because furthermore whatever we are discussing depends upon these important physiology and what we have to learn. So in the first case also, first, second and third case, whatever has happened is related to this physiology. So what is this physiology? Is lactogenesis happens in stages: first stage, second stage and third stage. When it is first stage, the progesterone is very high. There is a milk, the milk mother starts producing milk even as early as 16 to 20 weeks. Milk is available because progesterone is there. The release of milk does not happen. It is very similar, like milk is ready but the tap is closed because of the hormones. But as soon as the baby mother is delivered, what happens? The progesterone dips and prolactin starts appearing. This is where, if you give the baby to the mother given milk coming in happens and the baby starts suckling, they get the milk. And third most wonderful thing what happens at a later point, which we all have to remember, is on third fourth day, what we call as milk coming in, that is where the engorgement issues can happen. The breast is autocrine control. When I say autocrine, that means there is no need for any hormonal. If the baby sucks more, baby will get more. The breast tissue itself will have the control of how much milk should be produced. So if the baby has sucking more milk, less sucking, less milk will be there. So this is the phenomena we have to remember. So breastfeeding works with this dogma. So during pregnancy, hormones prepare the breast, birth turns the milk production on, but baby's suckling keeps going on. So suckling is so important for us. Two more things what happens is, whenever there is milk production, prolactin hormone is what is important for us. If the prolactin in blood is more, then milk production happens. So baby suckling will lead, gives a signal to the brain to produce more milk. So these things we'll have to apply at various stages where we are having issues. Then third point what I want to say is, in the second situation where the mother had some doubt that she did not have milk, so we have to understand the mothers have a oxytocin reflex. When a mother is in doubt or she is having any stress, worry that she is not having milk, the oxytocin reflex is inhibited, her production and ejection of milk comes down. So what we have to do as healthcare workers to promote breastfeeding is, you have to make sure that you talk to her, build her confidence, she make sure that she is confident to produce more milk. So we have to use these skills whenever we are counseling. And last part is, I said the engorgement has lot of issues in the mother. Other thing what engorgement, uncorrected engorgement does is the permanent decrease of the breast milk. There is something called feedback inhibitor of lactation. If the mother's milk is severely engorged, there is lot of feedback going into the brain to suppress milk production. So ultimately, if you don't empty the milk, the production also comes down. So we should make sure that we understand all these physiology whenever we are dealing with the mothers who are lactating.
As the breastfeeding is normal, natural, but yet few mothers feel pain. And is that the training for the instinct is required guidance to the mother?
Yes, sir. So we discussed a lot of issues. This is a pertinent issue which we have to deal with. Painful breastfeeding is something we commonly see in OPD as one of the commonest causes. We have to remember that breastfeeding is pleasurable and there is no pain involved. Many of us feel that a little amount of pain is okay. Mothers, grandmothers say it is, that is how it goes. But I just want to say in this forum that no amount of pain is normal. Okay, most of us try to say that if there is a pain, they start applying a local lanolin, EBM, whatever is there, or they give painkillers. But please make sure you address why there is a pain. So there are a lot of causes, but most important cause, if you look at this slide, is the positioning and latching. Here I've just put the latching video. A baby who is not latching, say here the baby is just sucking at the nipple, here the baby is sucking at the complete breast, so the good points of latching is all available here. So most important cause, and I would say really 80 to 90% of why the mother is having pain would be because of the wrong position. Technique is what is there. Unless we correct this technique, this can have a deleterious effect. I've listed a lot of causes here. I would say nipple pain is a Pandora's box. There could be a lot of maternal causes, baby related causes. So as a pediatrician or anybody, whenever mother comes to with pain, it's not natural. This is where our skill has to work. So what we have to do is make sure you assess what is happening, observe a feed, assess a feed, and assist the mother. So, this is very important. If the pain, if you have assisted and still the pain persists, please see if the baby is having any anatomical issues, tongue tie, or the mother is having any other breast issues are there. So, this cycle should go on in assessment. Final point about pain is I just told that oxytocin reflex is what is required for a mother to have increased milk production or ejection should be there. If she is in pain, this is one of the main factor where the pain inhibits the oxytocin reflex. Ultimately, the mother can end up in lot of issues. So we have to address pain. It is not natural. Here, the skill plays important. We have to assist the mother.
Hmm. Uh, when an exclusive breastfeed, a child is on exclusive breastfeeding, suppose,
Yes,
and
sir.
still they're not gaining weight, is that the technique is wrong or the milk flow is less?
Okay, so I would say that the first thing is what is important. So this is just a norm of what, as a pediatrician, we all know what is the normal weight loss, month to month weight gain, all that is there. So there is a physiological peak where the baby loses weight because of various reasons. Maximum a baby loses around 8 to 9% of the weight, but this is not because of milk is insufficient. It is a physiological loss. But many of us actually nowadays, if you think that breastfeeding can be assisted in the initial, that physiological loss might not also happen. If you look at this chart, this is chart from all our IAP and WHO. There are different norms are there. Each month there is a weight gain, say at 2 to 6 weeks where we know that 25 to 35 grams average weight gain is there. And red flags, we should know that in the initial period, if the weight loss is more than 10%, or in subsequently the baby is losing weight or crossing more than 2 centile lines downward, then only it is there. So physiological weight losses can be there, but pathological weight losses, if at all it is there, it is never, most of the times, mostly not because of low milk supply. It is to do with poor latch positioning, infrequent feedings, ineffective sucking, or there could be low stimulation, infant illness could be there. These are the main causes. We have to assess the breastfeeding and make sure that weight gain issues are addressed, and weight issues are not an excuse for us to start supplementation immediately. I think milk production is instinctive, but effective milk transfer is a learned behavior. When weight falters, it is often because of skill. It needs support and management rather than supplementation.
Hmm. Next, we go to if can behavior feeding pattern in babies falsely mimic milk insufficiency, and
Yes.
how a pediatrician tell the difference about.
Okay, so we have dealt a lot with the initial breastfeeding issues. This is something which I commonly see in our OPDs at a later point of time. Why I want to reiterate these points is third month, fourth month, anytime breastfeeding issues can happen. It need not come with only low supply or painful nipple. It can come in different ways. So sometimes the mother, the baby comes in at around 6 weeks. That baby is crying excessively. Mothers feel that baby is crying because of hunger. This might not be there. If the baby's weight gain is good, if the baby is feeding well, so it just could be a scenario where there is a growth spurt for the baby and the baby is having increased demand. If other parameters are fine, this behavioral issues with the baby of excessive crying, it could be because of other reasons. Let us not think that it is because of decreased milk production. The other point is that was in around 6 weeks, say at around third month or so, many a times babies get distracted. They hardly feed for 2 minutes, 3 minutes. What they do is they want to be playful. Here the babies have a increased environmental awareness will be there. The milk feeding or breastfeeding is least of their priority, so we have to recognize these breast behavior changes and make necessary changes. So what we have to do is recognize distractions, growth spurts have to be recognized. Sometimes the changing routines can also be there. So these are the factors which will undermine the mother's confidence. Here comes the environment. Make sure that we are supporting these mothers and say what is normal, and say that it is might not be because of breastfeeding, and encourage her to make sure that she continues to breastfeed.
Coming to the preterm babies who cannot latch immediately, how do we protect the biological instinct to breastfeed while actively teaching the skill needed for the child later on?
Okay, this is a little unique thing. So, preterm breastfeeding, it is only related to the baby most of the times. Here, the biology is present. That means the baby is having an instinct, but it is a little immature. So, the rooting, sucking, whatever is required, it is existing, but it is a little weak and uncoordinated. So, they might have certain low tone, poor suck swallow, breathing synchronization. All these can be low. So a lot of challenges they can face face as the baby is born. But what we have to remember, if you we remember 3 points, whatever I have told. First is about the biology or the hormonal things. So as soon as the baby is born, preterm is born, here also the milk production starts. At a later point of time, the mother will have sufficient milk production because the mothers will start secreting on third day, fourth day. That is there. And we already know that preterm milk is definitely superior. So a mother's milk will have more protein, more higher levels of EGF, and lot of other immune growth factors for the preterm. So preserving that is extremely important. Now that baby cannot suck, baby is in NICU. What are we supposed to do as a part of healthcare workers is make sure that mother's breast milk is preserved. So we have lot of pumps are there. We have lot of gadgets which can use. So first and foremost, counsel the mother. Make sure that she is in a positive environment, so her oxytocin is built up. Next is what we have to do is to make sure that the production and the maintenance of the milk supply is done. That is what is the prolactin hormone, whatever we are talking. Now baby is not sucking. What is an alternative? Make sure that we counsel her to start expressing from the beginning. So we know that more milk emptying, more milk will be produced. So this is how you can start to make sure that her milk supply is maintained for a long term. So we are maintaining the milk supply. As and when the baby also is ready to be fed, we'll make sure that there is a gradual transition from gavage feeding to cup feeding to partial breastfeeding. So we can start with non-nutritive sucking, and we have to make sure that oromotor stimulation is done for the baby and made sure that the baby is able to suck. So you have to prepare the mother and make sure that there is enough milk for her. Also make sure the baby is also ready. In preterms, the though instinct to feed is present, but it is unfinished. So what we can do is now with structured learning and gentle training, we can make sure that even a preterm feeds exclusive breastfeeding is possible.
Hmm. Coming to the working mothers, a lot of working mothers are now in our country, and how to combat that?
Okay, so we have to first make sure that working mothers could be a challenge. Here, there is a separation for the mother and baby. Many a times, it might be in different age groups. Say the mother has finished at 6 months, the challenges are different. If the mother is going earlier than 6 months, the challenges are different. So, what we can actually do is the body is naturally designed to keep producing milk. Now we know if the baby is not able to suckle, we have to make sure that the mother is using lot of pumps and other ways of making sure the milk is emptied and storage. So let her use a let down reflex whenever the baby is there, or whenever she is there, she can make sure that she expresses and stores it in the the required quantity for the baby. But all this preparation requires definitive time. Say she is joining the work, she has to start preparing 15 to 20 days earlier. make sure the production is maintained. So planned pumping schedule to match the baby's feeding time is required. And we should make sure, we should tell her what is the milk storage, what is the transport, hygiene skills has to be there. And communication at the workplace is also important to make sure that she is able to pump at the work. Here all our counseling and confidence building skills comes into picture to tell her that it is possible to continue to give her breastfeeding or continue to give the same amount of milk what she was giving. So transition from workplace to the family to the workplace is definitely possible in various ways. So counseling is what is required here.
Talking about the induced lactation and for the adoptive mother. Induced lactation challenges the idea of pure instinct. Does this shows that breastfeeding can be built through learning and physiology even without pregnancy?
Yes, a very interesting question that is. So, what I feel is we have been talking so far about challenges and mother, a maternal who has all the biological mother facing. Here, this is when you say induced lactation, the mother has not undergone any pregnancy, mother has never delivered but wishes to breastfeed. So, through science, it is still possible that this mother also, a mother who is biological mother, can still feed the baby. So is it possible? Definitely. So the first slide, if you remember, we had spoken about the hormonal changes, what happens here. So what we actually do in an induced lactation is we could give her a lot of medications in the initial period and make sure that she is ready as soon as the baby is born. Once the baby comes out, the all the other techniques whatever we are using has to be followed. The hormonal milieu will be there. As the baby borns, we will withdraw the hormonal milieu and start making sure that endocrine control is shifted over to autocrine control. So these mothers also, with the help of hormones and frequent stimulation, can start to breastfeed their own baby. So what happens here is mothers can have, as soon as the baby is born, skin to skin can be there, lot of kangaroo mother care can be there. And what she can do is, with the help of medications, if the baby starts suckling or if she can pump at a continuous point of time, even a mother who has never been pregnant is ready to feed the baby. So the biology is there even in the mother. If your technique or if the learning skills are imparted to her, even an adoptive mother can feed. This is similar to what we actually do in other situations. Sometimes there is a mother, biological mother, there is a gap, mother is sick, ill, and she's not been fed for a long time. So here we follow what we call as relactation. Here the mother has stopped for weeks or months and they want to restart. So regular stimulation, if the mother is given enough emotional support and patience, she can also restart breastfeeding. So in all these, what I would want to say is make sure that at any point of time, if we provide a foundation, if you counsel the mother and say that it is possible, even an adoptive mother can start breastfeeding the baby.
A lot of talk is going on in the country and across the other countries in the world about human milk bank. Whether it is a support system, is a substitute, or how do we keep the balance right?
Okay, as per what we can actually say is human milk bank is both bone and bane is what I feel. Definitely, it is a extremely powerful system. It is life saving for most of our preterm. Now we actually are seeing mushrooming of human milk banking. So in an extremely preterm babies, sick babies, it is life saving because it reduces NEC. Lot of infections are reduced. So it is an way ethical way. It is a human alternative and mother's milk is temporarily unavailable. What I want to stress is here the human, here we have to take this as temporarily unavailable is what is extremely important. though it provides reassurance during medical and other medical maternal emergencies, this should not be taken as the permanent way. So human milk has their own restrictions. They can be given only when the baby is inside NICU. If you don't support a mother to secrete enough, if she doesn't have when the baby comes out, there is no point in giving the human milk alone. So what points of caution we have to understand is, many a time unintentionally it so happens that to reduce the urgency, to actively support maternal lactation, donor milk is taken as an easier alternative. So over medicalization of these feeds happen. So not, it is not the fault of milk bank per se, but we have to make sure that there is, it is considered as a temporary bridge. So you have to have a proper lactation system, you should have a specialist support, you should counsel the mother. So we should always remember human milk bank is one part of it. Mother's own milk is definitely superior. Mother's own milk is more important than a human milk or a donor milk which is temporarily available. If you are not preparing the mother to biologically feed, this system of alone giving expressed milk or the donor's milk can be a counterproductive parameter can be there. So make sure that human milks can be used as a safeguards but not as substitutes for mother's own milk.
Very well explained by you, Dr. Nagalatha ji. But then, what are the final summary points?
Lot of things I would want to say, sir. So I would just say that breastfeeding is no longer a purely natural. We have gone through lot of cases, lot of case scenarios are there. I think that somewhere around the lane from intergeneration, initially there was breastfeeding was there in between because of lot of formula onslaught. Trend of equating formulas came into picture. So what we have to do is, earlier we know that girls grew up watching women breastfeeding. Today there are a lot of challenges like nuclear families are there, hospital births are there. So privacy norms mean first exposure happens after delivery, so often without guidance. So there is loss of intergenerational knowledge is there. So from one generation to another generation, passing of this knowledge is not there many a times. Many a times, because of various reasons, medicalization of childbirth has happened. So there is increased cesarean risk. Sometimes post-operative pain is there. IV fluids are given. Mothers are on medication. Sometimes NICU separation. All these are there. So these are the challenges which we are facing, where natural instinct is hindered. So we have to have a proper lactation support to make sure that breastfeeding is maintained. Also it is always we have to remember, there are, it is just not about the instincts. Many a times anatomical challenges can be there, functional infantile issues can be there. Sometimes unrecognized tongue tie can give an issue, high arched palate or a premature or late preterm, a hypotonic baby. These are various anatomical issues can be there. So these are to be seen, addressed. So natural instinct might not alone required. We have to have a skilled person to recognize this and help these people. Last, one more thing what we have to say is the formula exposure. So most of us, many a times these advertisements, formula owners have given us a scenario where formula is equal to mother's milk. So this erodes the confidence of the mother. So many a time unnecessary substitution becomes. This false equivalence shifts the baby feeding from physiology to support. So, whatever we are trying to do, mothers feel it is okay to give formula. It is equivalent to mother's milk, is what many of us actually feel. So, this is something which we have to address over a period of time. Finally, even if we have addressed all these, make sure that there is an unrealistic expectations. Many a times mothers have felt guilty that you are not breastfeeding. She should not be made a scapegoat, or she should not be made to feel that there is something going wrong. It is, make sure, tell her that we are there to support, make her feel not to feel guilty is definitely required. So all these factors I would say is, though it is natural, a support system is required and an environment is required for the mother to start making sure that baby is exclusively breastfed. So finally, I would say that breastfeeding is an instinct, but with a learning curve, it is not an automatic skill. Biology, though, initiates breastfeeding, our society determines whether it succeeds or not. So at each age or each challenges, we have to start making sure recognize the hurdles and help the mother. Breastfeeding rarely fails because of breast milk, so there is nothing like decreased breast milk, but it fails because of this lot of missed moments, missed skills, and missed supports.
So, lot of updates from you, Dr. Nagalatha ji. And I think all the pediatricians of Indian Academy of Pediatrics and public and listening mothers and pediatrician from this Dr. Tuteja talk show will be benefited. But if there is one thing we should do from today to support breastfeeding, in a sentence, what would you say?
Maybe in a sentence, it is very difficult. So there are a lot more here in 45 minutes. It is so difficult if I have to think. I would say that many of us believe that it is not possible. I think we should start believing that it is possible, and breastfeeding is a skill, and what we have to do, it is, and in biology it is there, but it survives only when skills, support, and systems stand behind the mother and infant diet. So belief that it is possible is something which I would want to say. And definitely when there is an issue, when we say for antibiotics, when you want to write an antibiotic, think before you ink is what we all say. I would also say that when a mother, when you feel that mother is not having sufficient milk, or if you feel there is an issue, think before you write a formula, or assess before you write a formula is what I would want to say, sir.
That's great. We should avoid the formula milk. We should promote the breastfeeding, which is natural, which Dr. Nagalatha has very well explained to all the pediatricians. The very lucid talk and on the breastfeeding, I have learned so many things and listened for the first time in such an elaborate way the breastfeeding practice in our country. Thank you so much being with us on the
No.
talk show, and we are really honored by your presence and hope so that you will come with a new topic sometime later whenever you decide.
Thank you
Thank you
so
so
much,
much
sir.
being with us.
That it is an honor. Namaskaram for from here only. It was really nice talking to you in person. Humbled and privileged to be here. Thank you so much, sir. Thank you so much.